Good morning, everybody. And I know it's a long weekend, so I appreciate everybody signing on early at 8. And so I'm Maura, MacPhee, and I'm going to be talking about the synergy model. And what I'd like to do is to give an overview of the model and its two major components. And then I'll talk about how it's being used in the Canadian context. And we actually have some people joining us by GoToMeeting from Ontario who are currently working with the model. And then there'll be time at the end for questions and hopefully some answers. There are also some handouts, and so I believe that Marilee has attachments for people who have joined by GoToMeeting, and then there are some handouts in the front of the room. And I'm not supposed to go too far from the microphone, but I'll just hand these out quickly.
For our remote viewers, in the reminder email that you've received about the session with the link to the session, there's also a link under details to the web page on the School of Nursing website, and on that page has the links of the PDFs of the handouts that Maura is handing out in person here.
So I became familiar with the synergy model when I was working with Dr. Martha Curley at Boston Children's Hospital in the early 2000s. And I'm just going to refer to Dr. Curley as Martha. Martha is considered the founder of the synergy model, or foundress. And Martha is a fellow in the American Academy of Nursing, and she's also well known for the research that she's done with children's critical care interventions. When Martha was working on her dissertation in the 1990s, it was a requirement in the U.S. to use a nurse theorist as kind of the conceptual foundation for your work, whether it was a thesis or a dissertation. So Martha got very interested in Virginia Henderson's work and decided that she wanted to focus her conceptual model for her research on the nurse-patient relationship. Oh, how do we switch the slides? Sorry.
Just click on the slide and then it's...
oh, here.
Yeah,
okay.
just click there, just once, and then you can use the...
Trying to get the slides to move, sorry. Okay, now we got it. Okay. So the philosophy that underlies the synergy model is that first you begin by determining the needs of your patient and their family, and then you can determine a nurse, the competencies of the nurse, their knowledge, their skills, their attitudes and judgment that are necessary to care for that patient. And another concept that's important to the synergy model is this idea of safe passage, that if you have a good fit between what the patient needs and what the nurse can deliver for that patient, then you get synergy, you get best possible outcomes, and you also get safe passage through the healthcare system. And so when Martha was working on the synergy model, this was really the advent in the U.S. of patient-centered, family-centered care, and also the quality safety movement. So the synergy model and its philosophy really encapsulates these core concepts. And this is just a pictorial diagram of the synergy model that Martha used in one of her first publications on the synergy model that shows kind of the yin-yang between patient characteristics and what nurses do, our practice. Martha wasn't satisfied with just developing a conceptual model for the synergy model, and so what she wanted to do was to really flesh out what types of patient characteristics are fundamental to critical care patients, and then what are the nurse characteristics or competencies that are necessary to care for critical care patients. And so she joined forces with the American Association of Critical Care Nurses, the AACN, and they used an expert panel and use the Delphi process to flesh out 8 patient characteristics for critical care patients and then 8 nurse characteristics or competencies to meet those needs. And this was trademarked. The original model of the Synergy model was called Synergy Model of Patient Care, and it was trademarked by the AACN. Subsequently, other work that was done with the Synergy model has shown that those 8 patient characteristics and 8 nurse characteristics are universals that really work in any sector, whether you're talking about general practice or you're talking about a specialty population. And they also work along the developmental continuum, whether you're working with pediatric patients or adults. In 2001, the Clarion Health Systems in the U.S. adopted the Synergy model as its patient care model, basically its philosophy of patient care delivery. And Clarion Health Systems is the largest healthcare provider in Indiana in the U.S. And so they have been using the patient care model as kind of their philosophy of how to provide care. And their healthcare system covers that continuum from quaternary care facilities all the way to home care. When it was first adopted by Clarion, Carleen Kerfoot was the chief nursing officer for Clarion. And she's written a number of papers about how they actually use the Synergy model as kind of the basis for their healthcare system and really transforming their healthcare system to be more family-centered. In 2002, Duquesne University in Pennsylvania adopted the nurse characteristics component of the Synergy model to use as their academic curriculum framework, and they're still using it for both their undergraduate and their graduate programs. Now, another concept that's from the U.S., but that's making its way globally now, and it's also in Canada now, is the idea of a magnet hospital. And magnet hospitals are hospitals that have certain characteristics in the work environment that act as a magnet to recruit and to retain nurses. And one of those components of a magnet-like environment is a professional practice model of nursing, where professional practice model of nursing is nursing's philosophy of the care they deliver and what's unique about what nurses do for patients. Baylor Healthcare in Texas was the first big healthcare system in the U.S. to adopt the Synergy model as its professional practice model of nursing. And one of the handouts that you have is a very nice little summary by Baylor that talks about the professional nursing practice model. And this slide is kind of hard to see, but this actually is what they have on their website that describes professional nursing practice that's really kind of core to a healthy work environment and professional nursing practice delivery. This little handout also describes the Synergy model. It talks about some of the terms around the Synergy model, such as safe passage. And it also describes the 8 characteristics for patients and the 8 characteristics for nurses. So it's kind of a handy little overview of everything you want to know about the Synergy model and also about those work environment characteristics that are really fundamental to magnet hospitals. Since then, a number of other healthcare organizations in the U.S. have adopted the Synergy model as either their patient care model or their professional practice model of nursing. And then finally, after about a decade of work with the Synergy model, Dr. Martha Curley decided that she would do a publication of all of the work that's been done to date with the model. And so through a collaboration of Sigma Theta Tau International and AACN, they came out with a book. And I'll just hold up the book. This is the book, but it's well loved. I've got it dog-eared and underlined, and it has some great examples of how to actually operationalize and use both components of the Synergy model. And of course, Martha is the editor for that book. So I'm going to skip over this slide since you have the handout. And one of the things that we know about healthcare delivery is that it's always changing. Care delivery models are always changing. So when I talk to students about care delivery model redesign, what I say is that the most important thing and what should stand the test of time is the nature of the nurse-patient relationship. And what does that look like for professional nurses? And this quotation from Martha that's in the book is probably one of my favorites. Without this relationship, nursing becomes simply the carrying out of tasks and activities in virtually a void of essential information. And so one of the things that I think is a very worrisome trend in Canada in particular is how our scopes of practice are really kind of being deconstructed into tasks and activities, rather than recognizing the holistic nature and the special nature of the work that we do and the unique aspects of that nurse-patient relationship. So for me, the Synergy model embodies something that really goes beyond just patient characteristics and nurse characteristics. It really, to me, is what I believe is critical to the quality of our profession. Before I go into a description of the two components of the Synergy model, another thing that I want to point out about Synergy is that when Martha was developing it, the conceptual model, systems theory and complexity science was also becoming very important in the U.S. And so the Synergy model uses a systems approach to assessment and care of patients. And this is another quotation from her book, that consideration is given to the patient, family, community, biological, psychological, social, and spiritual dynamics, as well as the patient, family, community developmental stage. So when we talk about using nursing process, we use a systems approach with the Synergy model. So I'm going to start talking about the first component and where you begin with the Synergy model, and that's looking at the patient. And so the part of the Synergy model that is about the patient characteristics is sometimes called patient assessment, patient characteristics tool, but there's an actual tool that's been developed so that nurses can rate their patients on each of these 8 characteristics. And I've underlined individual because you have to remember that it's the systems focus. So there are these 8 characteristics, and I'll give definitions of them in a moment. But what I wanted to point out is that there's a rating scale for each of these 8 characteristics that goes from 1 to 5. And it's very similar to the Canadian triage assessment scale that's used in the emergency department, where 1, 2 indicates high needs, a 4, 5 low needs, and a 3 is in the middle. What we found in acute care and critical care environments is that it's often, the nurses will often take these 8 characteristics and they'll subdivide them into what they call acuity characteristics and capability characteristics of the patient. This isn't necessary, but it seems to fall out that way for making staffing decisions. And that, I hope, will become more evident in a little bit. But the reason why I've split this into acuity and capability is this is what a lot of acute care and critical care environments tend to do with these 8 characteristics. What happens when you're developing or using these 8 characteristics as a patient characteristics tool is that you have nurses and nurse managers that get together, they look at their patient population, and for each of these 8 characteristics, they decide on what's an example in their patient population of a 1, 2, 3, 4, 5 for each of these 8 characteristics. So there's this shared decision-making that goes on of looking at the patient population and developing actual indicators and exemplars for each of these 8 characteristics. So when I do this work, as a consultant, or if I'm giving advice on how to do this for a particular context, I often use a participatory action research approach. This is the form of research that works well when you're using the Synergy tool or when you're introducing it to a different patient population and nurses. So stability talks about the steady state of the patient, how labile they are, their vital signs, their mental status. Complexity refers to the number of systems involved. Predictability is where that individual is on their illness or their wellness trajectory. Resiliency is the reserves of an individual and their capacity to return to baseline after they've had an illness or an injury. And vulnerability is a term that's linked specifically to safety. The idea that an individual may be at risk of harm for falls, if they have delirium, if they have dementia, if they are someone who has mental health addictions problems and is homeless in the downtown east side. It can also mean if they're immunocompromised or if they have a number of lines or tubes or treatments associated with them. All of that increases risk of harm and risk of complications. The capability characteristics focus on the individual and the family's capacity to perform activities of daily living, to make rational decisions, and to have resources available to return to baseline and to be productive or to have a sense of health and well-being in the community. And this is just a hypothetical example that I put together, and I'm not an adult nurse, so I don't know if this is feasible or not, but this is a little case that I put together of a 64-year-old female who has been admitted, not admitted, but is in outpatient clinic for an exploratory laparoscopic procedure because of stomach pain, weight loss. The patient goes in for the laparoscopic procedure and there are complications including blood loss, variable level of consciousness, and there is the discovery of a walled-off tumor in the stomach that's a new diagnosis of cancer. So how I coded this is that stability is 1 because you have labile vital signs and blood loss. Level of consciousness is variable. For complexity, I've put a 1 because you have multi-systems involvement. For predictability, I've given a 1 because this is not a typical postoperative course for an outpatient procedure. For resiliency, a 3 because we don't know. She's a 64-year-old. She doesn't have any known comorbidities or health issues, but there's a new diagnosis of cancer, so that opens up a lot of questions about what's going to happen. For vulnerability, it could be a 1 or a 2. This individual right now is unable to communicate her needs, and she's dealing with a new diagnosis. She also has unexpected complications and different lines now for treatment that put her at risk of infection. For participation in decision-making and care, I've scored a 1 because there's no family present with her, and she's unable to communicate her needs. And for resource availability, also a 1 because it's largely unknown how she's going to be able to cope, especially with the new diagnosis of cancer and no family involved. So this is just an example of how it works, and what typically happens is when you have nurses and you have management working on this together, they get very comfortable understanding the scoring system and the terminology for their patient population. This is an example from Niagara Health Systems, and it's an example that of what they've put together for their surgical patient population on 5A. And you'll see that acuity has those first 5 characteristics, and then capability has 3 characteristics. So this would be on a patient's Cardex, and nurses can pencil it, and then they can change it depending on changes in patient status. So this is considered a real-time staffing tool that can be used to identify what are the patient needs. And you can very quickly look through and see where are the 1s and 2s, if there are any, where are the 3s, where are the 4, 5s, so that this can help for staffing.
But on that one, Maura, they've done 1 is low by the time.
Yeah, well, it depends. You have to change the language,
Yeah.
right?
So I came in with the Baylor or whatever tool and then looked at that one.
Yeah.
Be quick to use. I got everybody at a 1,
Yes.
or a lot of people at 1 who were really at risk.
So 1, 2 means high needs. 4, 5 means high needs, and low needs, and 3 is in the middle. Those are kind of the universals. But with the language, sometimes the scale is reversed, but the 1, 2 means the same thing.
Unless they're high functioning or low.
Yeah.
Okay.
Yeah. It does get confusing, but 1, 2s always means high needs. Right. So when you have the individual scores for the patients, you can use it as a handover for transfer, as a shift-to-shift report. You can use it for interprofessional rounding, and as I mentioned, you can use it on the Cardex for each patient and also to plan their care. And an example that you have in the handout is from Baylor in Texas, and it's an example of their exchange report guideline where they've actually used the language of Synergy to report off what's going on with the patient. And again, you'll see where they've used kind of a systems approach. They've put examples of what to look for, what are those key indicators that are important for their particular patient population. And this exchange report is for medicine, surgery, and telemetry. Oh, one of the things that I really like about the Synergy tool, or I'll say the patient characteristics tool, is that you can average those scores. So you can get an average score over those 8 characteristics, anywhere from a 1 to a 5. You also can split it so that you get an acuity score, you get an average capability score per patient. It just depends what the nurses and managers want to do. But those average scores can be used for making safe staffing assignments. They can also be used shift to shift, day to day, week to week, however nurse management wants to use them to look at patient population trends. They also can use it for workload distribution. So you can see how many 1s and 2s you have on your unit at any given time, 3s, 4s, and 5s. And if you know from report, for instance, from the ER that you're going to get some 1s and 2s, or you're going to get some new patients back from the OR that are going to be 1s and 2s, you can proactively make workload requests and bring in extra nurses. So those numbers can be very beneficial, especially to management. You can also use it for research, and so I'm actually doing a study with Susan de Hinton and with Farah Javier where we're doing a time series design where, and we're doing this with Niagara Health systems in Ontario. So we've collected data on nurses and patients and on the unit for 12 months before the introduction of the Synergy tool for safe staffing, and then we're going to be collecting data for another 12 months after. And what we're looking for, what our hypothesis is that use of the Synergy tool for safe staffing will lead to improved outcomes for nurses and patients and the unit. So for nurses, we're looking at things like overtime, sick time or sick leave, turnover, job satisfaction. For patients, we're looking at nurse-sensitive indicators or adverse events that happen that can be prevented with safe staffing. Things like hospital-acquired infections, pressure ulcers, falls with injuries. And then for the unit outcomes, we're looking at things like lengths of stay for different types of patient populations, and there are also financial indicators that can be tracked. So the other thing, I think, I'll give some examples when I talk about the Canadian context, but what I'll do now is just talk a little bit about the other component of the Synergy model, the nurse characteristics tool. And it is based on 8 characteristics, and just like the patient characteristics have to be contextualized for the patient population, nurse competencies have to be contextualized for the patient population. The original model that was promoted through AACN was created by Patricia Benner, and it uses a novice to expert approach where the numbers are flipped. So 1, 2 are novice or beginner nurses, the 3s are proficient or competent, and then the 4, 5s are expert nurses, and sometimes even advanced practice nurses, depending on the setting. And when I was at Boston, we used this model as the blueprint for really determining professional nursing practice. We used it for creating job descriptions for different levels of nurses, for different patient populations, and we also used it in our annual performance reviews for nurses. And these are the nurse characteristics, and I'm not going to go through all the definitions. They're on that handout from Baylor. You'll notice that many of these things are professional standards within our scopes of practice and for the College of Regulatory Nurses. What is it? CRNBC, College of Regulated Nurses of BC. Or Registered Nurses of BC. I'll get it right one of these times. So, and then there are some additional ones, as you'll see, such as systems thinking. One of the reasons why the nurse characteristics component has been used less, especially for safe staffing, is because it was developed for baccalaureate prepared nurses and advanced practice nurses with higher degrees. So if you have a staff mix or a skill mix where you have LPNs, if you have care aides, if you have non-nurses such as social workers or mental health workers, you can't use that for making staffing decisions. So instead, what I found works very well is to make staffing assignments based on scopes of practice, employer policies, and also the healthcare provider's knowledge of the patient population and their comfort with the given context of care. So these are some examples from Canada. So one of the first projects I got involved in, probably around 2006, was the BC Provincial Nursing Workload Project. That was a collaboration with the BC Nurses Union, the Ministry of Health, and then the chief nursing officers of the health authorities in BC. And we had 8 volunteer practice sites, and we had 2 sites per 4 sectors. So we had 2 sites in acute care, 2 in mental health, 2 in long-term care, and 2 in community public health. And what resulted from that is a toolkit that actually walks people through how do you use the synergy model for your patient population, how do you make safe staffing guidelines. So that toolkit is available. It's on the BCNU website, and I also have been sharing it with colleagues across Canada. So it's been used in Saskatchewan and Regina. It's been used in acute care, and right now I'm having conversations with Regina Hospital about using it for their emergency services department. In Ontario, Hamilton Sciences Centre took the toolkit and basically used it on their own. I wasn't involved. They were able to follow the toolkit and enact it on their own. They're using it in acute care, critical care, and they're also using it for interprofessional rounds. So it's become the standardized terminology for the other disciplines. And I've mentioned Niagara Health Systems. This is a new project that just started in November, and I think Chris Choi was on the go-to meeting, but Chris is the project team leader, and he's been doing a phenomenal job. And some of the tools that I'm going to be sharing with you are ones that were developed by Chris and his team in Niagara. And then in BC, it's being used in Fraser Health, currently cardiac services, but they are planning to roll it out to other medicine and surgery areas throughout this health authority. Now, I apologize, I've left out lots of people's names, but I want to just highlight a few of the leaders who are involved with the Fraser Health Authority initiative. Marg Malash, Barb Hall in Surrey Memorial Hospital, and Nancy Edge, who's the director for the CCU of Abbotsford Regional Hospital. And they've all been leading the rollout of the Synergy tool in their different cardiac areas. How this got started is because Marg Malash originally was the nurse manager for one of the first pilots that we did in 2006. It was very popular with her staff, and so when she moved from Vancouver Coastal to Fraser, she took the Synergy tool with her. So she's really been a strong advocate for the Synergy tool. Now, when I've done it, I typically suggest 2 to 3 days of training. What happens is that there's a project team, a volunteer staff, usually 8-10 members. That includes the management, educators, and then staff who represent the direct care providers for that patient population. So it may be RNs, LPNs, RPNs, care aides, social workers. It just depends on that patient population. And these individuals go through and they figure out the indicators for those 8 characteristics for their patient population. And then there's a train-the-trainer approach that's used where they champion it and they share the tools they develop with their staff so that staff starts to use it for scoring patients and then for making safe staffing assignments. And it typically takes 2, maybe 3 months to roll it out so that you have good reliability among the different staff members. But it depends. One of the things that Fraser Health has been doing is that they haven't been doing release time at all. The educators and the managers have been using the toolkit. They've already created different resources for their staff to use, and they actually do the training during safety huddles and during in-services and staff meetings. So it can be very cost-effective when you come up with that approach to doing this type of training. We usually recommend that there should be at least a 90% agreement in how scoring is done by the nurses. And the toolkit also has information in there about interreliability and how you determine it. So I have a couple of handouts to share with you, and the one that is on the slide here is from Abbotsford Regional Hospital, and it's an example of their safe staffing guidelines that they've created. And I want to just point out a couple of them to you. And again, these were developed by the nurses and the managers working together. This is a very participatory approach. So number 3, for instance, patients who score acuity number of 1 or 2, high needs, require an RN who's experienced in the CCU. They need to have a CCU RN. And that means a more experienced nurse who has that special certification. High acuity patients, those patients receiving a score of 1, are best served at a maximum ratio of 1 nurse to 2 patients. So you can also establish nurse-patient ratios this way. And then some of their other guidelines also include ratios. They address capability, and then one that I especially like that's not on this, didn't make it on the slide, is number 9. A lot of times staffing is done by habit or it's done by geography rather than letting patient needs determine staffing. This one point that's made by nurse management and nurses of ARH is that RNs nurse patients, not beds. Therefore, if a bed move is required, the RN will follow the patient to ensure that patient continuity is maintained. So it's really focusing on the patient, and what I think it does is it really puts the patient, patient-centered care, family-centered care first and foremost when we think about safe staffing.
Maura, can I just interject?
Sure.
I just had this flash of a restaurant and how people might be seated to have one waitress managing them. Might we ever get to a point with beds where...
Well, that's actually one of the things that's happening at Niagara because they have pods. So they're trying to think of how one pod could be for patients that have 1s, 2s. But then you also have to be sure that you don't overwhelm nurses with all the 1, 2s. There has to be some balance. But what it means is that if you're looking at layout, if you're doing design, you really need to consult nurses and managers before architects get in there because that geographic layout is important to consider, especially from a safety perspective. And those are some of the trials and tribulations that Chris is having with Niagara right now. So these are just some other examples of different tools that have been created to use with the Synergy model. This is from Fraser Health, and it's what the charge nurses use 2 times a day. They record acuity and capability for each of the patients, and then they can look through that to make sure when they're making assignments that they do have workload distribution and that they're following their safe staffing guidelines. And then this is an example from Niagara, and this is one of the first versions. So the other things is that it's very flexible. You can start working on tools to use. If it doesn't work, you can go back, you can start over. So another one of the handouts you have is that this was one of the first versions when I started working with Chris and with Niagara Health. And then this handout is draft number 4. And so one of the things that they did when they developed an assessment tool for 5A for their surgical patients is that for each of the characteristics they have a brief definition. They decided that they would put levels 1, 2 together, then they'd have level 3, and then they put levels 4, 5 together. That was something that the nurses felt worked for them and with their patients. And then they have the indicators and then patient examples underneath. What is common is to kind of fall back on this idea of functions and activities. So it is very important when you're doing training with this is to pull people back to those characteristics and also to the systems approach so that you don't forget that we're really looking at individual systems and an individual nested within a family, a community, a population. And for community and public health, this tool actually has been used for caseloads, managing cases, so you can use it to characterize needs of a school or of a specific patient population. It doesn't have to be just for individuals.
Where all the patients that are there are 1 to 2. As I look at this list, I mean, that's what it seems to me.
Well, there was one long-term care facility when we did the pilot. Most of their residents were at the same level of needs as general medicine surgery. So you would definitely want more RNs than we typically staff in long-term care. It also speaks to the importance of specialized knowledge when you're caring for residents that have some of these complex needs in long-term care. And our program that we have now for senior care. So I'm going to end with this particular slide because with the research I've done, a lot of it has been qualitative. It's been using participatory action research. And to me, the synergy model is an empowerment strategy because what I've seen is that there's enhanced conversations between staff and management. There's a greater sense of ownership and accountability of nurses for the decisions they make to care for their patients. There definitely is shared decision-making that has to go on, and shared governance is another magnet-like quality of nurses' work environments, and this model definitely promotes shared governance. It gives nurses a greater sense of the holistic nature of patients and of patient needs, and also more of a systemic approach. And I've seen improved communications, and not only between nurses and management, but also with other disciplines. So these are just the references, not all of them. There's actually, I mean, the book itself has lots of great examples in it of how to use the different components of the Synergy tool. And then the toolkit and also the report from the Provincial Nursing Workload Project are available on the BCNU website, and I also have them. So I'll stop there and see if people have questions from GoToMeeting or the audience. Yeah, Suzanne.
No, Wendy.
Oh, Wendy? Okay, I didn't see Wendy. Okay.
So I was interested that you said that in some institutions they're using it as a tool as rounds, where they're getting all the different professional groups together. Has that happened more globally with that introduction of the tool, or is it just happening in particular settings?
It could be. It's just that I can't even keep track of where it's being used and how people are using it. I just happened to find out that Hamilton was using that way by accident because, now that people have the toolkit, it is pretty self-explanatory. So, I'm happy with people taking the toolkit and using it so that they can be using the Synergy model and the tools. But it may be, it's really being used in a variety of ways. It's the actual model where you use those two components together. That's happening in the U.S. Baylor, for instance, Clarion. There's some other states that are using it that way, but I don't even know how widespread that is. And up here, until, because it has to be used within an all BSN population, I don't know that that's going to happen. I think we'll be using the patient characteristics tool predominantly where you have skill mix. Suzanne.
So the thing that I like best about it is with my research looking at health communication, especially the interprofessional and the handover component. This tool would provide very easy, quick to pull together information. So, I mean, I'm even thinking of the obstetric, neonatal ICU area, that there are aspects of this that could be so beneficial. How do we balance it within our Canadian healthcare system and resource allocation and how staffing is done in that? That's the struggle I see.
Yeah, well, it is basically getting buy-in, from management, and again, when you have, like Marg has, with Fraser Health, has that credibility, and so she shared that with her colleagues, and they've taken it, and they're basically rolling it out throughout Fraser Health Authority. Well, we don't have that data yet, and I'm hoping we will get that from Niagara. In the U.S., surprisingly, there hasn't been that line of research. One of the reasons why is because this is a real-time staffing tool. It's also used more as a professional practice model. So in the States, a lot of times when they're looking at financial indicators, they have computerized workload measurement systems that really are at a higher level. And so they use that. This captures something entirely different. It really is nurse-driven. And so I'm hoping that the work we're doing with Niagara, that we'll be able to have some of that data to support why it is a very cost-effective strategy to use. Yeah.
Maura?
Yeah.
It's Cheryl. Can you hear me?
Yep. Hey, Cheryl.
Hi. I just had a question about, you had mentioned that this model really addresses the synergy between nurses and patients and families.
Yes.
I'm just wondering if you could address a little bit more about the family piece. Is family really just seen as the support system that is or is not in place for the family, or is there actually a more clearer link to addressing the needs of the families as well as the patient?
I think that that's part of that conversation that happens. And that's why sometimes it is good to have a facilitator involved to help take this tool to that deeper level, to look at it from a systems perspective. Because you do need to consider not only how you would rate an individual, but also the family, especially with respect to things like resource availability. So for instance, one of the things that I know that's happened at Fraser is that they've been more proactive in getting social services involved when they've recognized that they have resource issues, right? Or they have education issues, get the educator involved earlier. I'm surprised that some of those things, we just wouldn't know to do them. But I think that with the busyness of what goes on in healthcare and also the way we have kind of deconstructed what we do as nurses, we forget about the family. We forget about those other things we do besides the functions and activities at the bedside, that we do advocacy work, we do education, we do planning. And so I think the Synergy tool says you got the patient, you've got the patient in a family's part of a community out there. What kinds of resources do we have? What are their needs, and how can we help them to get back to baseline so that they can go out and be successful when they return home or to wherever they're going?
Could you see the possibility of further development of the model in terms of a rating scale for families?
Oh yeah, and it may have been used that way. Actually, Northern Health Smithers was one of our original pilot sites, and what they did was it was a mental health program, and there was a community component, and then there was an acute component. And what they did is they would often use it to see if someone was escalating in the community, what were the community resources, what were the family resources, and if they didn't have sufficient supports, they would assign the mental health worker to go out and spend more time with that individual. One of the things that they discovered, and I really urged them to publish this, was that by being proactive about that, they were able to control some individuals' exacerbations so that they could stay in the community. They didn't have to be admitted to acute care. So there you have cost effectiveness, right? And so the person who was the project lead was actually a mental health, he was a social worker, and they used a lot of mental health workers, and they were keeping tabs on how they were able to identify when a client was starting to have risk, that vulnerability, and where the interventions, the right interventions, could prevent an admission to acute care. But they had to look very closely at resources for the family as well as the community, if they were there or not. Gail?
Oh, yes. Hi. Can you hear me?
Yeah.
Okay. I had a question about evaluation. I'm not sure if Suzanne, I think it was. I couldn't really hear her question.
Oh, sorry.
I just heard some of your answer, so it sort of touched on evaluation. But you mentioned earlier that you were working currently on a research project that looked at outcomes for nurses, for patients, and for the units themselves. But I'm wondering if there has been any other evaluative pieces that have looked at that, because it looks like the Synergy model has been used through the 2000s in different capacities, mostly in the States. So I'm wondering if there has been some a look at the evaluation of it.
It's mostly been qualitative, and in terms of outcomes, not as much research has been done on that. There has been psychometrics testing done with the tool in different settings. Barbara Brewer has done a lot of that work, and she's in Arizona now. I haven't actually followed up with some of the people who've been doing that research in the States to find out what they're doing to use it to track outcomes, because they have data management systems and they have other data sources that they tend to use to do that rather than using the Synergy tool. So what I'm hoping to do with the Niagara study is to get some of that data to help support why it's important, because I realize, especially when you're going to administrators, that having that hardcore data makes a difference.
Mm-hmm.
But I think,
and also for the nursing schools that are using it.
and
again,
yeah.
Yeah, I'm wondering how they're liking using the tool as opposed to what they were doing before, and I'm not sure if there's any data on that.
Yeah, well, Duquesne is still using it. So they started using it in 2002, and they're still using it. I went to their website just to look at what they have posted, and they do talk about how they use the Synergy model for both their undergraduate and their graduate curriculum. And so I'm sure that they probably do have more data on it, but I'd have to contact colleagues at Duquesne and ask them how that's working out. I've been mostly interested in that patient characteristics tool and using it for making safe staffing guidelines.
Okay, thank you.
Yeah. Yes, Prisha.
Question. In terms of implementing it on a sort of a unit level, how is it that staff buy-in is, how you get staff buy-in? Because I know sort of with the acuity and with all the things that nurses have to do nowadays, it's like, oh, one more thing we have to do. And is there anything that is fed back to nurses to sort of keep them motivated to keep using the tool? Or is it just self-evident that they see the value?
Well, I think that by participating in coming up with the indicators and what does this mean for their patient population, they get invested in it that way. It also is very quick to do. So once you know how to do it, it's very easy to go through and to score patients, and sometimes they don't change, so you don't have to change the numbers. But I could always do it in a few minutes, typically just run through and do it. So it's comfort with that, but nurses do want to see some payback for that. And so one of the things that Niagara has found out, for instance, is that their night shift in particular, they didn't need more nurses, they needed more care aides, because the nurses have so much paperwork, they have orders and they have medication reconciliation. There's a lot of things that are designated to night shift, and they just couldn't answer call lights and kind of keep up with some of the more mundane things on the unit. So it's identified for them that they need more care aides. So it also helps you see where your needs are, and it's not always another nurse. And so now they've been very appreciative of the fact that using the tool, it's helped to identify for them what their staffing needs are on night shift, and they get care aides when they actually have staffing guidelines that tell them when they can make a request for an extra care aide. Right now, on day shift, they're working on guidelines for when they can request another RN or an experienced RN. So when they see that it helps them get more staff, or it helps them get the resources they need, then I think that it is seen as something that's quite valuable to them. But you really do need to have leadership support. You need organizational support to really reinforce the use of this tool. And so one of the things that happened with Niagara that was quite unfortunate is that after they got their project started, the nurse manager ended up actually going to Hamilton. And so they were without a manager for a couple of months. They just had an interim manager helping them out. And now it's kind of like starting all over again with a new manager. And what I asked is that I asked their chief nursing officer and their director to really get behind the new manager and the project team to support the work that's been going on. Because otherwise the staff do get cynical if they don't see that it's being utilized to the benefit of the staff and then hopefully the nurses as well. Oh, thank you.